Defensive Medicine, Cost Containment and Reform by Laura Herman and Dr. Howard Brady. The role of defensive medicine in driving up healthcare cost is hotly contended. It is hard to find a physician in America who does not believe that defensive medicine, fueled by the present malpractice system, is a major driver of excessive healthcare cost. Yet, at the same time, many health policy analysts argue that the total contribution of malpractice cost to healthcare cost inflation overall amounts only to a minuscule percentage of total healthcare cost, and thus that malpractice reform is unlikely to lead to substantial cost savings. It is our perspective that both positions contain some truth but ultimately are incomplete. First, we will define defensive medicine and identify problems in quantifying the practice. We will then examine and evaluate the strengths and weaknesses of the positions expressed by both physicians and the policy analysts. Defensive medicine is commonly defined as the ordering of treatments, tests, and procedures primarily to help protect the physician from liability rather than to substantially further the patient's diagnosis or treatment. Defensive medicine is a very difficult thing to measure. It is also defined by subjective factors, the physician's beliefs, rather than objective ones. The physician perspective. Studdert and colleagues in 2005 survey that 93% of high-risk specialists in Pennsylvania and 83% of Massachusetts physicians reported practicing defensive medicine. The existing evidence, there is a seminal study by Kessler and McLennan examined Medicare expenditures and mortality and morbidity rates in all states for myocardial infarction and ischemic heart disease. It compared states that had instituted malpractice reforms with those that had not, and concluded that defensive medicine cost accounted for approximately 5 to 9% of total healthcare cost for patients with acute myocardial infarction. Defensive medicine is only one among many causes of unnecessary care, as well as a culture of practice driven by higher reimbursements for procedure and technology-intensive management. It is also evolving clinical standards as another factor. Tort reform's role in cost containment. In addition to the psychological toll that it inflicts on physicians, the present malpractice system is incredibly inefficient. There is minimal overlap between negligent acts that harm patients and outcomes that prompt lawsuits. As long as both physicians and patients in the United States are prone to believe that high cost and high technology care are superior to low cost alternatives in providing good care, physicians would reasonably refuse to comply with these cost containment measures unless they can be reassured that they will not thereby expose themselves to increased liability risk. It is possible that the full impact of defensive medicine is greater than what has so far been measured. Defensive medicine is not the only sole factor in driving cost. The top other two reasons are use of costly new technologies and drugs, and spending 20 to 30% of healthcare dollars towards administrative works. Tort reform is a necessary but insufficient ingredient of cost containment. Reform may also be less likely to yield a reduction in defensive practice if the likelihood of being sued are merely reduced rather than completely eliminated. Tort reform by itself will do little to reduce cost unless liability concerns are successfully addressed. It is unlikely that most physicians will be willing to adopt the systemic strategies needed for cost control. One of the questions that can be asked is, does the physician need to discuss the cost of treatment with the patients at the time of treatment? And is there any other way for the physicians that can be used to contain cost in defensive medicine? An estimate of almost $300 billion goes into defensive medicine in one of the studies done.